Great. Thank you so much, Christy. Good evening, everyone, and thank you so much for taking time out of your schedule to be with us tonight. We especially want to thank Dr. Trockman for his time and being with us tonight. My name is Amelia Bartolotta. I'm a local representative with Medtronic. My partner, Ellie, is also on camera with me. She and I are the local Medtronic team that work closely with Dr. Trockman and the procedure that he's going to be talking about this evening. Dr. Trockman is a board-certified urologist. He did his residency at Loyola University here in Chicago, and then went on to do his fellowship at Kaiser Permanente in Los Angeles. He has lived and been operating and working in the Chicagoland area for over 20 years. He's raised his family here. He's a fantastic physician that we have had the honor to know and get to work with over the years. So again, thank you, Dr. Trockman, for your time. And as Christy said, all of the Q&A is anonymous. So as things go on, please feel free to put them in the chat. And then at the end, we'll have a few minutes for Dr. Trockman to answer any of your questions. Thank you so much.
So thank you, Amelia, and thank you to the Medtronics team and all the people at UroPartners that helped us put this on. This is really an educational discussion about overactive bladder. It's something that I've been taking care of pretty much every day that I work for the last 30 years in practice. And unfortunately, a lot of the patients who have these conditions, they've been suffering with them in silence for a long time because it's kind of the question that's not asked and the symptom that's not relayed to the doctor. And so patients don't really realize, people don't realize that you don't have to live with these symptoms of excessive frequency of urination and urgency and leaking urine. And it has a major impact on people's lives. It changes the things that they do, whether they are willing to go out and do social activities, and that affects intimacy. It can affect jobs. So it's a very, it's a significant condition. And unfortunately, a lot of people don't realize that there is help. And so that's why we're here today. So thank you for being here to learn more and maybe share with others that might need help, that there are things that we can do. Next slide, please. So, what are the definitions of, bowel and bladder control problems? Normally, when we say urinary frequency is voiding more than 8 times a day. Also getting up in the night from sleep more than twice a day, or leaking urine uncontrollably. And then fecal incontinence or stool incontinence is when you actually have stool soilage that occurs unexpectedly. And that is also a horrible condition that I think people are even more quiet about and don't tell their doctors about and suffer with. It causes a lot of distress. So we're going to talk about all these things a little bit more as we go along, and what we do to evaluate these conditions and what we can do to help patients who are suffering from them. So, next slide. And it's not a rare problem. About 1 in 6 adults have bladder control problems, and about 1 in 12 adults in the United States have bowel control problems. These are huge numbers of people. And unfortunately, as we've talked about, the number of people who are seeking help is relatively small. So a large percentage are suffering without the benefit of the current state of medical knowledge, which has increased over the last few years. And we can't help everyone, but we can help most patients. And it's definitely worth a try. As we talked about, it's not just a quality of life and social issue. If you're getting up a lot, you're not sleeping, and we all know that can affect your health. It can affect your confidence, your self-esteem, your intimacy and relationships, and your work can be affected. So it impacts multiple areas of your life, and that shouldn't be discounted. Next slide. So fortunately, there are a lot of helpful treatments. and ways to manage bowel and bladder issues. And we're going to get into that a little more. Next slide. So clearly, when I see a patient, I'll do a history. Is one of the first things I do just as a doctor, and I'll get an idea of what are you doing with your daily habits. I mean, occasionally I'll see someone who's drinking literally 3 to 4 liters of fluid a day, or 10 or 12 cups of coffee a day. And those are extreme examples, but in a case like that, cutting back those things can really change that patient's symptoms. And so it's important to get a good history and understand if there's anything that people are doing in their daily life or not doing that could be contributing to their symptoms, and we can help with something simple like that. Some medications like diuretics or other medicines that might affect the bowel can cause urinary frequency, having to rush to the bathroom, urgency, and leaking, especially the diuretics, which that's the purpose of the medicine, to get fluid out of your system. And it's going to go through your system, end up in your bladder. And if your bladder has issues, it's going to aggravate your condition. And then, of course, pregnancy causes a lot of physiologic changes, and sometimes that are during pregnancy and even afterwards, and other surgeries or injuries that have occurred, or neurologic conditions. So as a physician, my job is to evaluate the patient completely. And I'm not thinking about treatment initially. My initial evaluation is to go through everything that's going on and make sure there isn't a significant underlying condition that can be adjusted, perhaps by changing diuretics and working with the patient's doctors to maybe change medications, but also to get a clue, could there be something more serious going on, like bladder cancer or a new diagnosis of multiple sclerosis or Parkinson's. And sometimes as a urologist, I'm the first one to make that diagnosis. So, these symptoms you shouldn't just ignore. They should be evaluated, because in some cases, it leads to a diagnosis of even something more significant that can affect your health in even, ways that you didn't imagine. Next slide. So let's talk a little bit about how the bladder works now. And the bladder is not a very smart organ. Okay, it's just a flexible vessel that holds fluid. Okay, so as your body is cleansing your blood, you create urine, and that urine flows down to your bladder continuously, and your bladder fills. And normally the bladder will just fill at low pressures because it's flexible and will expand. And then you get signals from your bladder towards your brain, which tells you, hey, my bladder is getting pretty full. And this is, we're getting to the point where the bladder doesn't want to hold anymore. And you're getting those signals. And then what happens is your brain says it's okay to urinate. And hopefully that's in a socially appropriate time. So in other words, you've already kind of made your way to the bathroom and you're at the toilet, and then you urinate. If the bladder and the brain aren't working well, that trigger or that reflex can just happen much sooner. And then that's when you're clenching, trying to avoid leaking and running to the bathroom. And it's a very hard thing to control once it's started. And there can be a lot of neurologic reasons for this that could be that could cause it, such as spinal cord injuries or MS or Parkinson's. And that's why a thorough evaluation is needed. But in some people, it's just bladder dysfunction. And it's interesting that kind of modulating and working with that brain, spinal cord, bladder, pelvic floor reflex can control symptoms. And we'll talk about that a little more about some of our more advanced therapies. And as far as the bowel, it works similarly. The bowel fills, and the brain tells the bowel when it's acceptable to evacuate. If that process isn't working normally, then you have the stool soilage and accidents, which are obviously very embarrassing and a big problem socially. And fortunately, the interacting with those nerves between the brain and bladder can help. I want to talk a little bit about some of the different types of incontinence because it gets a little bit confusing. The bladder, as I said, just holds urine. And if it holds urine but isn't able to empty urine, eventually it overflows. And that's called overflow incontinence. And that's a bladder that's not emptying. Interesting, some of the advanced therapies where we stimulate the nerves to the bladder, and we'll talk about that later, can help that condition as well. There are, of course, other reasons people can't empty their bladder in men, large prostates or neurologic conditions, but that's overflow incontinence. Another type of incontinence is stress incontinence. And some people associate that with emotional stress, but it's not. It's physical stress, coughing, laughing, sneezing. When you do something where you're straining and raising abdominal pressure, if the valve mechanism doesn't seal, then you're gonna leak and that urine's gonna come out. And so that's a condition called stress incontinence. We have great treatments for that. I treat that all of the time as well, but it's not overactive bladder, okay? So leaking when you cough, laugh, sneeze is not overactive bladder, and that's really not what we're talking about today, but there are good treatments for that. There are patients, though, many patients who have both stress incontinence and urge incontinence and overactive bladder, and then that's working with your doctor, you figure out which you're going to treat first and which is the bigger problem. Can we go back to the last slide, please? And I think we've covered all that. The fecal incontinence is another issue we'll talk later at the end. We can advance probably 2 slides. So we talked about urinary retention. That's where the bladder does not empty. And in those cases, you may need a procedure to open up the prostate or treat any underlying neurologic condition and work. In worst case scenarios, you need a urinary catheter. There is a small subset, as we talked about, of patients with urinary retention who do not have obstruction and don't have a known neurologic cause who can benefit from advanced neurostimulation procedures like the InterStim device we're going to talk about later. Next slide. So overactive bladder is that feeling of a bladder that won't hold enough urine, and also sometimes even leaking urine. And sometimes the leaking can occur without the feeling. So there can be triggers. I have patients tell me when they get home and put their key in the door, or when they're in the cold section of the grocery store. So there are triggers that kind of start that whole reflex and process, but it's a very difficult thing to stop. And one of the things that we do is we work on trying to interact and intervene in that reflex with behavioral therapies or sometimes neuromodulation. If patients have overactive bladder with frequency and urgency and they're unable to stop their bladder contraction before they get to the restroom, that leads to the incontinence and needing to use pads and protective garments. As we talked about before, the definition of excessive urinary frequency is more than 8 times per day. Sometimes we'll see patients who are going 20, 25 times a day, and they're completely miserable. And then there are other patients who maybe through their whole life only went 3 times a day, and they'll come in very much complaining that, all of a sudden I'm going 6 times a day. And I'll say, well, things have changed, but it's probably not enough. We'll evaluate things, but that's not something that probably needs to be treated. So some people just don't understand what's normal. Getting up once a night, especially as patients get older, there can be many causes of that, including sleep disturbances, breathing disturbances like sleep apnea, and all those things should be investigated because those can be contributing to your symptoms as well. Next slide. So fecal incontinence is, again, when you lose control of your bowel involuntarily. And there are many, many causes of this. Usually this is worked up by a gastroenterologist, and they'll make sure there aren't any significant GI conditions or anything that's going on with your diet, et cetera. and try and manage that. But for patients who do not respond to conventional therapies and the standard therapies, the advanced neuromodulation techniques can help. And I've had, as a urologist, sometimes I don't take care of that primarily, but patients will be referred to me to do some of the neurostimulator implants that we're going to talk about, and it can make a dramatic difference in patients' lives. Next slide, please. So there are many things, once you've been evaluated and ruled out all the things that are reversible or medical conditions that we need to know about, there are many treatments that are available. Generally, in the past, we always said, oh, you know, you start with the simplest, easiest things first, and then you go to medications and then advanced therapies. And the simplest things are lifestyle changes, like maybe don't drink so much coffee, go to the bathroom regularly, lose weight, make sure your diabetes is well controlled, and so forth. And then if that fails, then you go to medications. And then if that fails, then the next step, you go stepwise to more advanced therapies. Actually, that's changed because we've learned that the medications don't work that great. They're expensive. And sometimes lifestyle changes, patients will spend months on that and do everything they can, and they're not getting better. And now it's really more of a shared decision-making process between the doctor and patient. You know, hey, what's going on? What have you tried? We'll, of course, always do the lifestyle changes because I do think that's a foundational treatment, that everyone should be drinking a normal amount of water and not taking excessive irritants, et cetera, and trying to lose weight, controlling diabetes and so forth. But we don't always have to go right to medicine because the medicines don't always work. And they're expensive, or they could have side effects. So the advanced therapies are available to patients much earlier, sort of in our treatment algorithm and our treatment plan than they used to be with current thinking on treatment of overactive bladder. Next slide. So again, we talked about diet, exercise. You could do physical therapy, which in my experience doesn't work that great for overactive bladder. It's better for stress incontinence, but it doesn't hurt anything, but it requires a big time commitment and is expensive. So, you know, these are all options, but and they can help patients, and I think they're a great foundation to start with, but many patients need more. Next slide. There are a lot of medicines out there. The main classes are anticholinergic medicines, which are like in the Benadryl family. Those medicines can cause dry mouth, blurry vision, constipation, and they appear to cause earlier dementia and memory loss. So in my practice, I hardly ever prescribe those any longer. They are less expensive, but I think they have a lot of untoward side effects, and especially in older patients. And so we try and avoid them. There are newer drugs called beta-3 agonists. They work pretty well, but they can also have side effects of high blood pressure and some other issues, and they're quite expensive. But I think they're a safer option than the older anticholinergic medicines. Next slide. Advanced therapies are what comes after medications have failed, or if you decided that, hey, I don't want to go with medicines, I'm already on 2 medicines, or the side effects or expenses is too great. And there are 2 ways to do neuromodulation, which are one of the advanced therapies. One is to stimulate the tibial nerve, and we'll talk about that, and the other is to stimulate the sacral nerves. And then you can also do an advanced therapy where you inject Botox into the bladder. Botox isn't appropriate or indicated for bowel control issues, but the neuromodulation can help. So next slide. So Botox is done typically in the office setting, and it requires placing a scope into the bladder and using a tiny needle. Small amounts of Botox are injected into the bladder wall, and this kind of relaxes the bladder muscle. The downsides to Botox are that it wears off. And so on average, about patients need retreatment about every 6 months. And patients can also develop urinary retention where they don't empty the bladder well because you kind of overshoot, and the the bladder gets a little too relaxed and lazy. And in rare cases, you can need a catheter after Botox. But that, fortunately, that's not very often. But because you don't empty your bladder as well, typically after Botox, there can be an increased risk of urinary tract infections. But it is a very reasonable option that many people choose for refractory or difficult to control overactive bladder. Next slide. Tibial nerve stimulation is sort of the least invasive way to stimulate the nerves and sort of influence that reflex and the nerve pathways between the bladder, the spinal cord, and the brain. And I kind of explain it to my patients as a little bit like electrified acupuncture. You're stimulating the nerves that stimulate the area of the spinal cord that talks to the brain and the bladder. And that can improve your urinary symptoms. It does require time commitment. So it's a very simple thing. There's a tiny little needle that goes above the ankle, and we do a 30-minute treatment in the office. We do that in 12 sessions. And if you're responding well, then you can come back once a month. I have some patients who like it, but most patients fall off the bandwagon because coming in every month for years at a time is a lot to ask. And so they usually look at something that's more permanent or implantable. Fortunately, I'm not going to talk about it much on the talk today, but there is an implantable tibial nerve stimulator that was just released by Medtronic, where that can be implanted with a small procedure so that you don't have to come to the office for the treatments. Next slide. The sort of the meat and potatoes of our talk today is an InterStim device, which is the advanced therapy that I do a lot of. I actually started doing these in 1999 when it was first FDA approved. I think I did the first one in Chicago once it was FDA approved. And this device stimulates the S3, the sacral nerve roots, by putting a small wire just above the buttocks next to the sacral nerves and stimulating that with a small little pacemaker that can be implanted can drastically improve patients' overactive bladder symptoms and urge incontinence. This works well. If you look at the data, historically, this has been used on the patients that have failed everything else, and yet the results are very impressive, that it really turns things around for many patients. It's a very minor outpatient procedure that's done when we put the full implant in. And the device can come in a rechargeable form, or the battery on the pulse generator, which is the little pacemaker device that's connected to the wire that stimulates the nerves. That can last 5 to 10 years, depending on the settings. And so it's a pretty simple thing. It doesn't interfere with lifestyle. You can do anything you want. And hopefully, in fact, it gets your lifestyle and quality of life back to where you want it. And that's the point. Next slide. So what's really neat about this therapy, it is a minor surgical procedure. But I tell my patients it's the only procedure that a surgical procedure that I do for them that you can take it for a test drive. Okay, so what we do is we do a test where we put under local anesthesia, I put a temporary wire next to the nerves that the sacral nerves that we're trying to influence to improve your bladder behavior. And I'll put that temporary wire in just above the buttocks under local anesthesia. And it's connected to a small little external stimulator that you just wear on a belt. And then the patient undergoes a trial of 3 to 5 days or so. And we put it in an approximately 30-minute procedure under local anesthesia. And it can be done in the office or surgery center setting. And then you come back and basically we know if it helps you. And if it works, putting the implant in has a close to a 90% success rate, which is very impressive. If it fails, and I'd say, at least in my experience, over 60% of patients who do the test, if they're appropriately selected patients, respond to the test. So we do the test and we sort out probably the 40% that wouldn't work, the therapy won't work for, but the 60% on whom it will, we get great long-term results. And the beauty of it is you get to take it for a test drive. You can see the impact that this therapy has on you and your bladder symptoms. And if you like it, we can move forward with the permanent implant for long-term bladder control. If you know anything about these devices in the past or had any experience with them, you weren't allowed to have an MRI if you had the InterStim implant in, and that's changed. The new devices are MRI compatible, and so it's not a big deal. I've had patients every now and then who, maybe a few years ago I couldn't offer to them because they had a condition they needed a lot of MRIs, and now I can put the implants in, or I've even changed out some old ones to the new ones. So that's a big advance for the therapy. Next slide. So, in summary, there are a lot of things that you can do for overactive bladder. It's a condition that you don't have to live with. Most patients we can help. And I think we went through everything. I think a thorough evaluation is important to look at all of the possible contributing factors and possible underlying medical conditions. But if you have overactive bladder that isn't responding, we can help you. In these advanced therapies, which unfortunately I don't think are offered to patients as much as they should be, are available. I myself do them at Uro Partners. We have several doctors throughout the city who do these. And so if you are interested in this, talk to your urologist. And if they're not someone who does InterStim or some of the more advanced therapies for overactive bladder or fecal incontinence, then come see me or one of my partners who do this. We're more than happy to see you and would love to help you. And then finally, as you can see from the slide, about 84% of patients who use this therapy are satisfied. Their quality of life is improved by a factor of 3. About 90% of patients using it for bowel control have success long-term. And this isn't something new. As I said, I put the first one in 1999 here in Chicago when it was FDA approved, and worldwide, there's over 400,000 of these have been implanted in. So it's a very good, it's a tried and true effective therapy. And that completes it.
Thank you so much, Dr. Trockman. That was great. I think Ellie's going to monitor our Q&A session here, but that was so helpful, and we really all learned. I even learned some new things there, so thank you for that. All right.
Yes, thank you again, Dr. Trockman. A few questions have come in. The first question is, what do you think about Myrbetriq? I use a generic when traveling, so I'm not constantly asking the group to stop. It's very expensive, but I get it via Canada Pharmacy.
So I think Myrbetriq is the generic Myrbetriq. It's a good drug. It's definitely safer, I think, than the anticholinergics, which, were the Vesicares and Enablexes and those drugs. But it is expensive, and it hopefully will get cheaper over the next few years because it's been generic about 2 years now, and the longer they are generic, then the cheaper they get. But I think if it helps you and you're tolerating it, it's a good drug. And I have patients who get it from Canada. I think even doing that, they're paying about $150 a month for the medicine out of pocket. So, that's a financial stress for people, no doubt.
Great. Another question came in regarding the trial. Can you speak more to what that feeling is like, and does it hurt? Is the question.
So it's a procedure. So yeah, there's a little pain because I use local anesthesia while I'm doing it. So that stings a little. But most patients get through it and don't think it's horrible. And we definitely have plenty of local anesthesia. So we'll use as much as necessary to make you comfortable. If the question is, what do you feel with the stimulation? That's another, I didn't mention that. And that's kind of interesting. Well, when we put the lead in, we actually stimulate it at the time to make sure we're near the nerve. And what we ask is if you feel sort of a vibration, and we call it the bicycle seat area, so that part of the body between like the anus and either the vagina or the scrotum in a man. And sometimes you'll feel like a little vibration or a little buzzing in that area, and that tells us we're near the nerve. And interestingly, you say, well, I wouldn't want to feel that all the time. You can turn it up till you just feel it and then turn it down, and it actually works most of the time. And even when you have that stimulation going, it goes into the background. Your brain kind of blocks it out. It's almost like, I would say, I'm sitting on a chair right now. And if I thought about it, I can feel the chair that I'm sitting on, but I'm not really thinking about that because you don't really think about it once it's there all the time, because it's not a painful stimulation. But I don't, every procedure, having your blood draw hurts a little bit, so I don't want to say it's completely painless. But patients get through it. And if someone has a pain issue, and we have patients who've been through a lot and they just don't want to feel anything, we can do it under anesthesia. There's an option to do what's called a first stage, where you can put a more permanent lead in under anesthesia, or even the trial lead under anesthesia. I've done that for certain patients if they're very concerned about pain. So we can work around it.
Just real quick, I see that there are a few people that have their hand raised. Unfortunately, the format of this Zoom, I can't take attendees off of mute. So please just go ahead and type any questions you have into the Q&A, and we'll be able to get them to Dr. Trockman that way. Thanks.
Okay, the next question is, would placing a sacral stimulator be appropriate for a person with significant arthritis in lower lumbar spine and SI joints?
So that's a great question. It's usually not a problem at all, because where this lead is going in is well below the lumbar spine. You're really in the sacrum, which is really just above the tailbone. And so the spinal cord and any spinal surgery that someone's had or major arthritis issues is going to be above that. So you can still have arthritis in that area that can make it a little challenging to get the lead in the right spot, but it's usually possible. I've done many implants in people that have, multi-level fusions, giant scars right above where I'm working, and have been able to successfully get a lead in.
Is pelvic floor therapy good, and what is it?
So another good question. So pelvic floor therapy, in my opinion, is best for stress incontinence, that leaking when you cough, laugh, and sneeze. And it's not perfect. Most patients get better. They don't, a small percentage get cured, but it's a healthy thing to do. For overactive bladder, pelvic floor therapy can help. And what it is basically learning how to exercise and stimulate the pelvic floor muscles. So if you think of a skeleton, okay, like it's almost Halloween, so you can think of that, and think about the pelvis. If you look down the middle of it, there's nothing there, okay? There's no bone, there's nothing to support everything. What's there are a bunch of soft tissue and muscles and ligaments. And that's very important to support everything. And that's where the valve is actually that controls urine flow. So when that's dysfunctional and not working well, it can affect the way your bladder behaves. So you're trying to exercise it and that and stimulate it. And pelvic floor therapists can work with you. Those are physical therapists who specialize in that area. And it can help. Okay. And I think the theory is great. I think in practice, though, with most of my patients, I don't see dramatic improvement. But if patients want to do it, I'm supportive because I know it might help a little and I don't think it will hurt them. But it's a big time and expense usually, you know.
Okay, next question. Does insurance and/or Medicare cover this procedure?
Most insurances and definitely Medicare covers this procedure for appropriate candidates. So there are guidelines about which patients are candidates, which there should be. And it's up to us as as your doctor evaluating to direct you towards appropriate treatment. So at least in Uro Partners, we don't have any trouble getting coverage because we're selecting patients that are appropriate for this. Now, there may be occasional insurances that don't cover it just because they're, not up to date, in my opinion, but I'm following modern medicine, but most do. And Medicare definitely does for appropriate patients.
Great. Next question. Does Parkinson's disease change the dynamic of using this therapy?
So another great question. So officially, if you have Parkinson's and a neurogenic bladder, and we say it's your bladder is affected by Parkinson's, if we think that's the cause, it officially, I think by FDA guidance, it wouldn't be approved because it's not approved for neurogenic bladder. That's, in my opinion, again, this is sort of, it has been used off label because I have patients who I have Parkinson. I'm not sure whether it's neurogenic bladder or just overactive bladder. So we try it and it works. So it can help. But I think it's more of a semantics than something that just completely rules you out. So it's possible and it has been used. And I know it's being studied. I know the Medtronics people, because of FDA reasons, can't say anything. I know it's being studied because there are people who believe it can be helpful. And there are many cases where patients who happen to have Parkinson's get the device for overactive bladder.
Okay, next question. Any physical problems with the implant after the procedure?
Well, like any surgery, I don't want to say there's never any complications or risks. There always could be a problem with the wound healing or an infection. It's an electronic device. There are a couple of connections. Those could have problems and malfunction, but it's rare. Okay, at least in my experience. Infection rates are very low. Most patients sometimes feel it, most patients really don't feel, but occasionally there is a patient who has a little discomfort from the device, those kind of things, but it's really minimal. Most patients get back to their full lifestyle. So if you like to swim, golf, run, jog, whatever, you can do all of those things after a short recovery period after the procedure.
And then just to piggyback off that, patient says, I'm 89 years old. Is it safe at that age?
It is. I will say when I originally started doing these, I would have thought, I'm not going to do someone that old, but maybe now that I'm older, that doesn't seem so old. But it is something that I have done in patients up to that age with benefit. So I think our mindset is it's really not just your age, it's the whole picture of the patient. So if you're an 89-year-old patient in a nursing home, not aware of things, that's probably not a good candidate. Probably a good candidate for any procedure. But if it's a vibrant, active 89-year-old who's not able to do the thing that's holding them back from visiting their family and doing the things they like to do, sure, it's not a dangerous procedure. I just think it, takes some thought and be reasonable and talk with the patient.
We just had another one come in, Ellie, on the other, we have two separate Q&As going on here. There's so many great questions, which is awesome. I just want to point this one out. Someone just asked, I have bowel control problems, mostly gas with small amounts of feces. Is this something that could help?
So it might. If I would say as a urologist, so I'm probably not the best person to ask as far as the initial workup, but if you've seen a gastroenterologist, a GI doctor, and gone through the full workup, and they haven't been able to help you, then I think it could be reasonable if they believe that's the case to, do a trial of the sacral nerve stimulation. I think there's very little risk to it. So if nothing else has worked, I think it would be reasonable. But I want to preface that by saying that you need to get a full evaluation with the GI doctor, just like I think if you have overactive bladder, you need a full evaluation with the urologist, like myself, who's interested in the condition and knows how to work it up properly.
Another question is, does someone need to take you and stay with you for the night? Or it sounds like maybe does someone need to take you up from the procedure? Or do you have to stay overnight?
Procedures. So for the trial procedure, no, where we just, I mean, there's several variations of how you can do the trial and so forth, but I would say 90% of the time for the trial, putting in doing the test, no, because it's done under local anesthesia. And I'll have patients drive to my office, to the surgery center. We put the trial lead in, and then they drive home and then come back to the office a few days later, and we go over how they've responded and take the trial leads out and make a decision whether to electively put the permanent implant in. Now, the permanent implant is done with a little IV sedation, okay? And the anesthesiologists have rules, and I think we all appreciate these rules, that you don't get sedation and then get in your car and drive home. That wouldn't be safe for you or other people on the road. And there are some people that, have issues later in the day for 24 hours after anesthesia. So just out of an abundance of caution, it's usually recommended that you need someone to drive you home and someone should be with you for 24
hours. Is the device suitable for stroke or a TBI patient?
So again, for neurogenic bladder, no. So if we think it's truly a neurogenic bladder, so if you just had a stroke and then had a stroke and that developed, after that, the urinary symptoms developed and the incontinence developed, it probably wouldn't be appropriate, but there might be select cases where you could consider it. But again, for patients who have definite neurogenic bladder, a definite neurologic cause for their bladder symptoms, it's not currently FDA approved.
Thank you. I'm just going to jump in real quick, Ellie. We have two good questions and we are going to kind of start winding down soon, but I'm so impressed with everybody's amazing questions. So thank you guys so much. One was a question about battery life for the implants. And I did just want to quickly clarify the battery that was shown in the picture does last 10 to 15 years. So the older one lasted closer to 5 years, but this new one we have is 10 to 15. And then the other question is, what town is Dr. Trockman's office at? I currently use UroPartners for many years, but this option has never been discussed with me.
Okay, so my main office is in Wheaton, but I also have an office in Geneva. And there are other doctors and UroPartners that are, might be closer to you that you can investigate. When you call, supposedly if you tell me you're interested in this, hopefully on the backside people know, but if you call my office or you were to come to see me, I'd be happy to take care of you. But if it turned out that it would be better for you to be cared for somewhere closer to you and there's an office with someone with experience with InterStim, we can get you set up that way too.
You want to do two more, Ellie, and we'll start to wrap up here.
No problem. Can you remind everyone, Dr. Trockman, where is the implant placed in your body?
So the InterStim implant is in the buttocks, basically a small wire that goes through what's called the S3 foramen, a little opening above the tailbone, as that's where the tiny electrode is that stimulates the nerve. And the implant itself, the pulse generator, the thing that looks like a little stopwatch about that size, that goes in the skin over the buttocks, under the skin. So it just goes in a little pocket in the skin over the buttocks.
That's awesome. Here's another great one that's come in. How does this device compare to the Vivali PTNS system where the patient wears a fitted wrap?
Okay, so that's an interesting therapy that is very similar to the PTNS, the neuro system, where you're stimulating the nerve. That's an external stimulation, so it kind of like I would say it's it's a little less direct form of stimulation because it's going through the skin and then stimulating the nerve, and then maybe putting the electrode in right next to the nerve. So either with the implanted tibial nerve. Now, that I'm aware of, there are no head-to-head trials between PTNS and the Bowel system. So we really don't know if one is better or not. The sacral nerve stimulation, in my opinion and experience, and I think the data shows it as well, works the best as far as all the forms of neuromodulation. And it kind of scares people because it seems very invasive, but it really isn't. It's a small electrode just going through a natural opening, and the implants is just over the buttocks rather than next to the ankle. So I think people sometimes think it's a bigger procedure and more involved than it is, more complicated than it is. However, the Bowel is an interesting thing. Now, that's something you can do at home. And, once you get set up with it, I've had patients interested in it. I haven't found anybody whose insurance would cover it. And that's been kind of very frustrating for them, I know. But it's an interesting therapy. And I think all of them may have a role, so I think it's great that all of these companies are working hard to help patients. So, I think time will tell. I wish I had more experience with it to share with you, but I don't, mostly because of insurance and coverage issues.
All right, we'll do one last one. Elle, if you want to give the last question, and then we'll conclude.
Yes. So back to the stroke question, what would work for someone that has had a stroke, medication, or Botox?
So Botox potentially can help for patients who've had a stroke. So the medications can work as well. And honestly, I believe that sacral nerve stim might work in some cases as well. It's just not FDA approved. So I'm going to kind of stick with things that are FDA approved for this form. But the medications, managing with time voiding, making a bathroom or portable potty very accessible, those are all can help in those situations. But they're no doubt they're challenging conditions. And when patients are very in stage with that and they come in and I need you to fix that, sometimes I have to be kind of brutally honest and say, well, are you going to the neurologist and saying I want to be able to use my right leg now? If it's affected by the stroke, they say, well, no, that's from the stroke. And I'm like, exactly. Some of these things are from the stroke. We can't just turn them off and make it all normal again, but we try and manage it the best we can. And I think that's the way to think of it. But there are things that can be done, but it's a challenging situation. But that's a very good question.
Well, thank you so much, Dr. Trockman, for your time today. Thank you to all of the wonderful patients that joined with your great questions. We had a wonderfully engaged group tonight, so I thank you all for that. As you can see on the slide here, there is some information for Dr. Trockman's practice, the phone number, as well as a link to make appointments. We will be sending out a recording of this talk tonight. And if you have a friend that registered but they weren't able to join, they'll be receiving that recording as well. So, Dr. Trockman, thank you so much for your time this evening. That was wonderful. And we look forward to seeing you soon.
Well, thank you very much. Can I just say one thing too to everyone, that I'm more than happy to see everyone who wants to see me. But there are also, like I said, there are many doctors, and there are several doctors, geographically spread out through the Chicago area, neuro partners, who do this therapy and are interested in it. So you can, see any of those doctors. So if you have established with the Euro Partners doctor, talk to them, let them know you're interested in it. And, they're welcome to call me, or, and we can get you set up with someone who can take great care of you in a convenient manner. Okay.
Thank you